Alrighty, hello everyone watching. Welcome to our webinar series called Pathways to Public Health. If you're just joining or if this is your first time joining this webinar series, my name is Dylan Huffpower and I am an admissions counselor here at the Tulane University School of Public Health and Tropical Medicine. And each week I have the honor of sitting with someone from our faculty who is participating in research, involved in our school, in some way, and we want to share their pathway to public health with you. And we want you guys to take away that there really is no set path to find a career and livelihood in public health. And so I'm excited today to introduce Dr. Walker. Again, he's a faculty member. And so I'm excited for you to hear a bit from him because he has a really unique pathway for his journey into public health that I am excited for all of you to hear. Like I said, we have one of these webinar series happening every week, and I'm excited to announce as well that I will now be sitting and chatting in this series with recent alum and recent graduates of Tulane SPHTM. But without further ado, I'm going to turn it over to you, Dr. Walker. And if any of you have any questions, please feel free to drop them in the Facebook Live comment section. I am monitoring that on my end, and I will relay those questions to our presenter. The floor is all yours.
Thank you, Dylan. Really appreciate it. I have some slides that I'll walk through, so just make sure you can see them. Can you see them?
Yes.
Great. So thanks again for taking the time to chat with me. I'm looking forward to sharing what it is I'm up to and my department, the Department of Health Policy and Management, some of the work that we're up to as a group. And I thought I'd start with just a few perspectives on my research and teaching life on campus and this part of the school. Overall, a lot of my research focuses on how different healthcare stakeholders, largely providers like doctors and nurses, who provide the care to patients, the payers and insurers who often pay for insurance and set the design and how care is paid for, and the patients and individuals who are navigating the system in order to improve their own health status, and really how they all interact and respond to different information and incentives that are often being piloted and launched in the space. These kind of topics include things like how insurers who maybe change the way they pay for care, how providers respond to those changes in incentives. Do they provide more or less care? Does it cost the system more or less money? How about the patients? Does that have an impact on quality for patient care? It includes other things like how patients or individuals like you, me, and others who are navigating new healthcare plan design, so high deductibles, different types of instruments that meter how we interface with our healthcare system financially, and how do we respond to those, and how do we respond to the prices in the system. I'm also interested in how behavioral interventions like nudges influence how physicians provide different care, or how patients respond differently, and if they get a targeted nudge about a healthcare service, would they be more likely to use it or not? So really how behavioral interventions as well. I'd say a lot of my research cuts across with a big emphasis on discrimination and equity, and I'd say topics of general unfairness in our systems with an eye towards measuring it and to try to understand what can be done to address them. This includes things like how do providers respond to information about patients, like demographics, race, ethnicity, sex, so forth, and vice versa. How do patients select physicians? Are they doing it with regard to these other demographic characteristics? This work also is kind of formalized through a lab that I co-direct with Dr. Jenna Wisniewski. It's called the Tulane Health Equity and Access Lab, or HEAL. And we do a lot of work in trying to measure these disparities, and we involve a lot of our grad students and undergrads as well in helping generate some evidence there. I'll talk about that in a slide or two. And then as far as teaching goes, I teach a doctoral course called Health Service Research Methods. It's for those who are in the PhD program in health policy management. So if you've recently been admitted or if you're considering a PhD in our department, it's a course that is a core curriculum for that track, and I'd love to have you in class. It's an area where I spend most of my time sharing the perspectives that I've gained from other researchers and on my own in measuring topics of interest to me, and also helping you develop the topics that you're really interested in and pushing forth research in that area. And so that kind of is a high level on where I sit in the school. Since I'm talking about teaching, I'll throw some kind of core research concepts out there and then share a bit about our research that we're doing in the Health Equity and Access Lab. A key question we often ask as researchers is, how do you know that something causes something else? And this is probably a very familiar idea for many of you, but it's how do you disentangle correlation from causation? Correlation, of course, being that two things appear to be related somehow. Maybe they both move up at the same time, or maybe one moves up and the other goes down, but they have some kind of apparent systematic relationship, versus causation, where you know that a change in one is inducing the change in the other. And it's super important for researchers because it allows us to identify, if we can get a plausibly causal design, to identify levers that if it's in society, it can be a policy lever that governments and other groups seek to advocate for, knowing that if you move one input, you're going to have a hopefully predictable output that moves in the direction you expect. So is increased funding in one area gonna, an investment in one area gonna reduce costs in another area or improve health in another area? These are the kind of causal questions that policymakers think of. Businesses and organizations also want to know, if you can change an input, will that have an impact on the output? Or is it more of a correlation situation where it's unlikely that a change in the input will affect the outcome? There are lots of things in the world that mostly present themselves as correlations, and it's unclear if you do anything to one, will it affect the other? It could be that the causation runs the other way. It could be that something unrelated to the two variables is actually driving everything. There are a lot of things that are going in there, and our task is to try to see the world, take a look at the things we're really interested in, and use the tools to get some plausibly causal relationship and measurement together to inform those types of management, organizational, and governmental processes. One tool that many are, I'm sure, familiar with is called a randomized controlled trial, an RCT. And basically what you do is if you have resources of time and funding, you can create your own research design where you have the ability to prospectively assign which group gets the intervention. And you have a control group who is on average the same as the treatment group, and there's nothing systematic between them other than the fact that you've assigned the treatment. And that allows you to compare the two groups and generate some estimates of whether something affects something else that is in a meaningful way. One type of an RCT that is out there is called a field experiment. It's basically using the methodology and deploying it in the real world to see if things outside the lab, like to learn about society, to use that method to understand how our healthcare system works. And a lot of the work that the Health Equity and Access Lab does is this type of research. So we focus largely on primary healthcare access, and there's a couple reasons for this. One is it's an important access point to the healthcare system. It's where a lot of prevention occurs. It's where referrals to higher orders of care, specialist expensive hospital stays, things of that nature, where often there's either a triage or a referral system going on to escalate if you need other types of services. It's where diagnoses can occur. It's where treatment can occur. It's like a really important part of our healthcare system among many important settings. We know that delays in access to care can really worsen your physical or mental health. So if you can't prevent something, or you can't diagnose something earlier and treat it before it gets worse, it's a setting where a lot of problems that were avoidable can be addressed. There are a lot of factors that affect access. You imagine that you can think through your own experience as patients at some point and think about what is delaying access. It could be where you live or the capacity of the healthcare system. It could be whether the system you have has good technology, so you can do telehealth versus not telehealth. It could be because your insurance and whether they'll accept your insurance, as a provider, or whether your insurance only has like a narrow network that you can access. There's like a ton of factors that can be involved. And our lab really focuses a lot on the role of racial and ethnic discrimination. So things unrelated to you as a patient or a person, but about how structurally access would be different by group due to discrimination. So I have two questions, and I figured what I would do is I'd ask these questions and then show you a little bit about how I do the research, and see, and then share with resources if you can dig deeper, and we can probably have a conversation about it as well. Always interested in new ideas to explore. But the two questions are, first, do doctors offer different appointments to patients based on race or ethnicity? And the second one, condition on the first one, is if yes, why do doctors offer different appointments? And I should probably say more like doctor offices. And so I'm going to take these one by one and then show you how we approached it and see how it goes. So the first question, do doctors offer different appointments to patients based on race or ethnicity? We designed a series of studies where we hired research assistants to call physician offices and actually ask for an appointment. And so one thing I'll throw out there is we probably hired 15 or so undergrad and graduate research assistants to help this research. We pay our researchers and they contribute, and they get to not only help generate observations, but also be part of the research process and learn about how to design studies. And some of them have carved out their own line of research from this. So, but first thing to parenthetically note is we're actively looking for people who want to be involved in this type of research, and we welcome anyone who's interested to chat about it. The second thing is, so the research assistants are calling offices to try to get an appointment. We made sure they said the same thing. So they had a common script. We rehearsed it, had various types of quality control, but mainly they have the same, the call they're making is to ensure that they convey that they have the same employment status, they have the same insurance status, they have the same health status, they have pretty much all the features that a doctor's office would care about or would ask about that are the same in the process of getting a health care appointment. The only thing we varied was race and ethnicity, which we signaled through name within their group. And so this was the, so to speak, RCT, randomized controlled trial treatment assignment. We assigned groups to be either white, Black, or Hispanic callers, and that allows us to compare Black and Hispanic callers to white callers. In this setting, we had, it was only female callers. We'll have more about male versus female differences on the next study. Then from this, we collected information on how the offices treated the patients, the prospective patients, in terms of what they asked about them, how they talked to them, what appointments they offered, and how far in the future they were. And then we used econometrics and statistics, some common tools that are used in our field that we would train our students on in order to measure if there are differences that are statistically significant, meaning that it's not very unlikely due to chance within a certain defined criteria. And then we can publish our work in a paper. On the bottom right, this paper was published in JAMA Network Open, and you can actually freely download it to dig deeper and see what else we did. So based on this design, what did we find? We found that practices asked questions and offered appointments differently based on race and ethnicity. So the question is, how much and to what level of confidence? We found that Black callers were 44 percentage points more likely to be asked about their insurance status before they even talked about appointment availability. So there's certainly a disparity in concern from the offices who have been randomly assigned prospectively on the front end to be on average the same by group to ask these questions more often. To give you a sense of magnitude, that's about twice as much compared to white callers. Hispanic callers were also more likely to be asked about their insurance status, about 50% more likely. And so there's a concern about ability to pay just based off of the signal of race and ethnicity, not based off of any features about the individual. Once they got an appointment, Black callers were offered appointments that were 3.5 days or so later into the future. So there's a longer delay. That's about twice as long as the white group. And similarly for Hispanic callers, it was also at a delay. So we're definitely finding through this design that practices are asking questions differently to these patients and offering them inferior times on average later and longer into the future. So it really led us to the second study, which is why might they be offering different appointments, and what mechanisms and what settings is it most notable? And this is actually research we did with folks in the faculty of Portland State University in their Department of Economics, where they have a similar study but has a longer time horizon, so many years and many states. And they also included men in it. So it's Black, white, Hispanic, male, female, as well as varying the insurance type they had. So we can see, are there differences by sex in addition to race and ethnicity? Are there differences by insurance status, which kind of conveys a little bit of economic perspective to help us understand and isolate where we're seeing the biggest challenges. So I'm going to show you a table. I hope it's not too scary. Some of you, it might be completely intuitive, but I'm just going to break it down and hopefully it makes sense. But I ask you, don't be scared when I put a table up. So here it goes. So I mentioned that there's 6 groups. So basically there's Black men and women, there are Hispanic men and women, and there are white men and women. So that's 6 groups. In order to understand how a group is treated differently, we have to have a reference group. Our reference group in this case are white women. And that's at the bottom line. If you can see my cursor, way to read this is that white women, when they called in this experiment, and we made 11,000 calls, got an offer of an appointment 65% of the time. And so in relation to white women getting an offer of an appointment 65% of the time, how did each of the other groups fare relative to that number? So the way to read this is from top to bottom. Black women receive about 4 percentage points fewer appointment offers. Hispanic women, 6 percentage points fewer offers, and all the way down the line. Net of all this, every group compared to white women had between 3 percentage points and 6.5 percentage points fewer appointment offers, which if you divide that by your reference group, what that means is every group had got an offer 5 to 10% less in comparison to white women. And this was statistically significant at least a 90% confidence level. That's what 1 star means. And the more stars there are, that means the less likely this is due to chance based off of the estimate and the measure of precision that's in there. So anytime you see stars and a blue highlight, that means that the numbers are statistically significant. So what we get from this is that intersection with sex and race and ethnicity does matter. And that whereas in the other appointment project, we were looking at questions about insurance and delay in appointment. Here we see that there's also fewer offers of appointments. So the next part of this table is going to be looking at each of the different insurance types. So what is it different for if you're in Medicaid, or just if you're on Medicare, or just if you're self-pay or commercial insurance? The numbers I have here are the whole group combined. And controlling for which group they're part of. So let's see what it looks like if you break it down further by economic or insurance status. And the main thing to come here is you see a lot of stars go away. You see many of the negative signs go there, but you see especially in the self-pay area that the effect sizes are bigger, and they're still statistically significant. So the effects here are largely driven by what's going on in the self-pay market, where you don't have the same insurance. There's a concern about whether your ability to pay is acceptable to the practice. And on average, the Hispanic men and women have much lower levels of access within the self-pay market, but they don't hold for the other insurance dimensions. So we looked at this further. We say, well, tell me about how they're talking to the patients. Are they telling them they won't accept their insurance? Are they telling them that they're not taking patients? Is it about health concerns that vary by group? So I'll go to the next slide and show you similar table, but breaking it down into different outcomes. Not just are they offered fewer appointments, but are they asked different questions. And so same idea. As far as level insurance accepted, pretty much every group at some point was less likely to have their insurance accepted, even though they are, in the case of the full group, on average, had the exact same health insurance. and in the self-pay specifically, they definitely have the same health insurance. Even though they have the same health insurance status, they're told that their insurance is not going to be accepted at a much higher rate. Similarly, for whether they're told about that the practice is not taking any new patients, most groups pretty much were also told more often that they were not taking new patients. And the magnitudes of these effects are also larger in the self-pay area. And there's no difference in the concern of health. So it's not driven by concerns of health, it's driven by concerns of the ability to pay to some degree. It's strongest in the self-pay area. And so what do these two studies tell us? It's basically from the first one, patients are asked different questions about ability to pay, namely insurance status, before they're able to get offered appointment. When they're offered appointment, they're offered later appointments. Intersection matters between race and ethnicity intersected with sex, as does insurance status, where the margin where it's the biggest concern is self-pay markets. So it gives us a little sense of where to focus. If there is an effect overall, but a lot of these effects are strongest in the self-pay market. So for policy and for other perspectives, that's an area where the biggest disparities persist, and that provides a space to focus. So hope that wasn't too scary. I'm happy to chat more about this for those who are interested. And the paper is published and available online below. But so next steps from this, what can we do about these inequities? We are actively doing projects where we're piloting provider nudges, targeting physician office practices and other provider groups to try to reduce the probability of inequities in the future. We're helping try to understand whether things patients can say themselves can help improve their levels of access. We're also interested in a lot of other settings. We have projects in reproductive health and access to behavioral health that are ongoing. We focus on other groups, including East, South, and Southeast Asians, members of the LGBTQ communities, Indigenous and Native Americans, Alaska Natives, Native Hawaiians, as well as members of Middle Eastern communities, and ongoing work. And we're always open to other ideas and other energies and settings to do research. So that's kind of a high level on what I'm doing and what my work is in the department. As far as my pathway, I figured I'd share a high level, both educationally and professionally. When I was an undergraduate, I studied molecular biology. I thought I wanted to be a lab scientist. I decided it wasn't for me, but I liked the field, but it wasn't for my career. And so I explored other things. I was an intern at the National Institutes of Health, and then I was a special researcher as well, looking at human subjects research topics. I did stuff on campus and college and health promotions, really thinking about community health and campus health. When I got into the work world, I was mainly doing consulting with concerning insurers and providers and how new therapies make their way into practice and how they're either reach barriers or reach facilitators to help them actually become part of standard care. I also did a lot of work in data analysis, looking at cancer care and cancer research, and as well as like market research. While I was there, I did a couple of master's degrees, a bit overkill, but in finance management and policy. And I basically realized it's not going to end. I'm really interested in these topics. And so I just continued, got a PhD in economics and joined the department a few years ago. A couple of things I take away from this that I hope is helpful is that I didn't have a grand strategy in my path towards public health. I pretty much followed short to medium term interests. They were all like a couple of year things of a topic that I was really interested in, and then tried to immerse myself in and get better at. And they all had a dimension of public health in it, but it wasn't like I thought I was doing public health. I was just doing things I thought were interesting that had to do with health or medicine. And in hindsight, there might seem like there's a bit of a tie into public health the whole way, but with foresight at the time, I wasn't looking in that direction. The second thing is I don't have a degree in public health. And I think that's an important dimension of the field, in that my experience is that the field welcomes a lot of different perspectives. Many of my projects, while I focus a lot on the empirical quantitative side, have a qualitative complement to try to help understand some of the reasons why behind what I'm measuring and where and how I'm measuring it. I think the field welcomes a lot of perspectives. It welcomes a lot of different viewpoints, and especially welcomes individuals who can identify questions that others who may be fully steeped in the traditional straight and narrow path may not have seen. So those are kind of my takeaways, like follow your passions, follow your interests, and there might be a tie-in later. And whatever you've learned along the way is valuable because there's a lot of diversity in thought and perspectives that are welcome that improve the research and push it forward. And with that, I'll say, pause there and just say thanks for hearing me out. Here's if you want more information about my research, I have a personal website that has my research on it, brigwalker.com. I have a lab website for the Health Equity and Access Lab that I work on with Dr. Wisniewski. And then my email address is bwalker6@tulane.edu.
Thanks, Brig. That was awesome. And the first thing on my mind after hearing you talk is one of the number one questions that I always ask faculty members, professionals in the world of public health that I meet. And you kind of already answered it, so I'm sorry that I'm making you answer it again. But because your pathway is so unique, you just really encourage people to follow your passion, and if an interest comes up, to kind of go with it. Is there any specific advice you have for someone who has found public health later in life and they're already done with their education and they want to continue following that passion in public health? Do you have any specific advice for someone who didn't study it in undergrad, or someone who is new to the world of public health but wants to stay in it?
Sure. Just a couple of things that come to mind. One is don't think of it as a clean break from your past, but a continuation from your journey. Many research that is really impactful comes from those who have experience and were able to live in the institutions that researchers are often interested in. And that perspective can help you identify really good questions. If you can maintain your networks, it may also allow you to have really good research collaborations with folks who are actually in the world, providing the care or implementing the policies that we're interested in. And even better, you might know people who have access to data that is otherwise unused or inaccessible to researchers because you were the missing link. That was the network between the researcher and the data. So that's one thing. Keep your networks and keep your perspectives in mind, because there's a lot of value in it that directly leads to things that researchers care about, which is research and publications. I'd say otherwise, if you are coming to it later in life, think about really carefully about like what it is you want out of it. I think having a vision that emerges through time can really sharpen your motivation for making the investment, not just in money, but in time and opportunity costs. Like I suspect many folks feel the way that I did when I was working for 10 years and then went into academia. It was like changing a career, like deciding to invest in your analysis skills rather than just to continue to make money, or if you can do both, even better. But to be thinking about what it is you're trying to get out of it, and then and keep that in mind, not just for the purpose of helping you sharpen your focus as to what classes and the electives I want to take, or what program I want to pursue based on what I know I am interested in and what I know I want to develop skills in, but also to power you through it. School is never meant to be easy for anyone, even though it may be easier for some than others, but it's hard work, but it's worthwhile work, and it's made more worthwhile if you know exactly what you're trying to do and what you're trying to get out of it. So just be thinking about what it is you want out of it, and keep that in front of your mind as well.
Awesome. You mentioned how important knowing your network is, and I completely agree with that. Can you talk a little bit, or have you, in your time at Tulane, been able to connect with any of your students in helping them be a part of your research or find a niche area of public health? Can you just talk about how you connect with your students in the classroom or beyond?
Yeah, I mean, so starting with classroom, because I teach health services research to, really motivated doctoral students. I designed the course to be fully about helping them develop the thing they're interested in. So it's not like, here's all the work I did, read this, read that paper, read that paper. It's like, let's practice some of our empirical skills using statistical software. Let's practice presenting your ideas. Bring to me, so, like, here's the method we're talking about. Bring to me a paper that you think is interesting to share with the class that not only would help you advance your own research by being part of your background and references and, like literature review, but also like practice kind of like communicating the things that are interesting to you. All this is for the purposes of developing research and helping advance a topic that you care about. So in the classroom, that's my entire focus. It's not about them taking my course. It's about them learning how to produce research that's meaningful to them and rigorous through the eyes of their eventual colleagues. As far as outside of the classroom, I have, I do fund a couple of grad students and undergrads in helping them develop their dissertation, like topics, or helping them contribute to the work, especially around the Health Equity and Access Lab. And that's where, part of the arrangement is, aside from me paying them, is also us working together in ways that, drive towards them being independent researchers who will graduate and continue their path towards independence, whether it's in academia, government, public, private sectors, you name it, wherever they would like to be. The goal is that they can get to that point, and that ideally we can work together and publish together, and that's good for everyone, including those who are interested in the research.
Absolutely. And now that we're talking about outside of the classroom, I want to ask you about your experience in New Orleans. We obviously, our student body is encompassed of students from all walks of life from around the world, and many of them, their first time on campus is that first time they visit the school, or maybe the first day of class. So what is your favorite thing about getting to live and or be in New Orleans? Is it the food, the people, the music, combination of everything?
Yes, and yes. So in addition, New Orleans is a buyer's market for food, music, and a lot of those things. Even after the pandemic, there's good opportunities for good, safe takeout. I say other dimensions. It's a city that has enough of a city to give you the city when you want it, and to let you quickly retreat from the city if you want to be more in kind of like residential neighborhoods, parks, that kind of stuff. I'm married and have 2 daughters, and we spend a lot of time kind of away from the city. But like when we first came here, we were a little more interested in being in it. So I have a little bit of both. It's another thing is that there's, and I think this could be a good or a bad thing. I think it's a good thing. It's small enough so that you can have overlapping communities. So you do one thing in one part of your life, and you people that you like and you cherish and are part of your community, and then you do something else, and there's a chance that there's like 1 or 2 of those people in that other community that are also in this other part, and it gives you a real good sense of, I'll see you at insert other thing I'm interested in here, and then it really kind of deepens the experience with the place. And the last thing I'll say is it's a city that just like likes to have fun. Like for me and my kids, we try to be really silly. I ride around with them on a 4-wheel bike called a Surrey. It's kind of like like just imagine like a Flintstones car that with bicycle wheels, or like a golf cart where with like a bicycle like drivetrain. I mean, it's a really silly thing. We put a basketball hoop on the top of it, so when it's Mardi Gras, people would throw the throws on the top of our thing, and it gives a shade. I mean, it's like a really fun kind of eccentric thing. And I think my favorite thing about it is like we'll bike around, and most people won't even bat an eye at, because it's a city that likes silliness and fun things, and that is not outside the norm. I've seen people rolling around my neighborhood in recliners with motorized wheels and a drink in their hand. So it's like a city that likes to live and have a good time. So those kind of things are really fun, because it's like, it's one thing to say you like the food, you like the music, you like the fun, but the community is really nice, and the overlapping communities are awesome, and everywhere you turn, there's something silly that can make you smile.
I think you said that perfectly. That put a huge smile on my face. And I'm hoping in the near future we get to have Mardi Gras and our parades back and festivals and all those fun things that we can't do now. So fingers crossed for that. As we wrap up, I just want to say a huge thank you to you for giving us an hour or so of your time today. We appreciate our faculty members being so willing, not only to be a part of the students' academic journey in the classroom, but outside the classroom, and being so helpful and outward facing to, I know, prospective students who will watch this video or watching now. So again, thank you so much. If you are just joining us recently and you didn't catch part of today's webinar, this Facebook Live will stay up on the Tulane SPHTM Facebook page. It will also be uploaded to our Tulane SPHTM YouTube page, as well as our LinkedIn school page. So several options for you to watch this video a little bit later. I have some other exciting faculty members coming up in our webinar series, as well as some recent graduates and alumni of Tulane SPHTM that I am adding to the lineup. So we've got an exciting few webinars coming up. And again, thank you all for watching, and I hope you guys have a great rest of your Wednesday.
Be safe.
Bye-bye.